The old thing I always talk to the guys and say, well, that's what's so funny. We're a lot more successful.
Not suited for media. No, you're so I was so 2 days or 3 days before. I think it will take 30 minutes because I'm practicing so much
They're fine for me.
Oh, is that right?
This way, and then they will steer this way.
We have to decide.
Yeah, I do.
Wherever you go. South Carolina.
When did you present Butch?
That's why. That's very
Yes, exactly.
The sessions. When do you go back? Oh, we just saw that, right?
I know. But then
I'm Christoph Zielinski. Very pleasure. Thank you. Sure. Wherever. I don't know what I'm saying.
Yeah, you're here.
I'm sorry. Good morning, everybody. It's my pleasure to welcome you to this press conference of this day. I'm Christoph Zielinski. I'm chair of the Comprehensive Cancer Center here in Vienna, Austria. And it will be a pleasure to present to you the outstanding abstracts, 4 outstanding abstracts, which were considered to be of such importance that they should be presented to you during a press conference. We have a little bit of a change in our schedule because Paul Baas has to leave a little earlier because he has a commitment with another session. If you allow me, I just introduce the group. Maybe everybody of you could say a couple of words who or where he is coming from. Why don't you start?
My name is Shirish Gatgil. I'm a professor in the Department of Oncology at Cancer Institute, Wayne State University in Detroit, Michigan, USA.
Julien Blanc, oncologist at the WCLC Cancer Center in Paris, France.
I'm Marina Garassino, medical oncologist, and I am the chief of the thoracic unit dell'Istituto Nazionale dei Tumori in Milan.
I'm Dr. Julie Bramer. I'm the director of thoracic oncology at Johns Hopkins in Baltimore, Maryland, United States.
I'm Paul Baas. I'm head of the Department of Thoracic Oncology of the Netherlands Cancer Institute.
Okay, so you see the panel is of very high quality scientifically and also in the academic arena. And we'll be starting with Paul Baas, and the idea is that there is a presentation given by everyone, and then as Paul has to leave a little earlier, I guess we'll have to do the questions going to him right away. Otherwise, we were supposed to have a common discussion, but I think you can ask Paul right after his presentation. Please.
Well, thank you. I would like to report on the phase 2 study, single-center, non-randomized, in which we tested nivolumab, a checkpoint inhibitor, in patients with recurrent malignant mesothelioma. Well, it's very clear that, first my disclosure, this is important, of course. First of all, it's important that you know that for malignant mesothelioma, which is an orphan disease, but it develops after asbestos exposure. There is only a standard first-line treatment. And second line, we have tested a lot of different medications, but only now we think that for second line we might get something. And of course, as you have heard on this World Conference, immuno-oncology drugs are very, very popular, very important. And this was one of the reasons why we also thought we are going to test this in mesothelioma. It has been done before by Dr. Evans, who also reported during this meeting. Long duration is a phase 1b study that he reported on. But what we felt was that you need more data, especially translational research data. There is an expression of PD-L1 that we all know that might indicate for a response, but it's not the best biomarker. So what we did, we had 34 patients, as shown here in this very busy swimmer plot, and we looked at the different colors. If you see something blue, it's an epithelioid type. Green and the dark blue, these are the non-epithelioid type. And we looked at the expression of PD-L1, and we looked after the administration of nivolumab if these patients had a response or not. So it's clear from this graph that you have, on the bottom, you have a few with the yellow diamond of patients who really respond well. And this is something, this is very promising. However, the PD-L1 expression was not related to that. So this is something of importance to know. There's also a large group, as we see with non-small cell lung cancer, that also do not respond to immuno-oncology. So we need this kind of translational research to identify the patients who are going to give these treatments or not. Because if you start a treatment which is not successful, you're only wasting the time of the patient, probably the quality of life, and in this case also a lot of money. And I think this is the summary of my presentation.
Thank you very much, Paul. Thank you. You're free to ask. Please go ahead. Please, sir.
Ian Davenport from Medscape. Just a quick question, really. With non-small cell lung cancer, we see there is a correlation between response and PD-L1. Here we're not seeing that. Why do you think?
So this was part of the discussion of yesterday's session, one of the sessions I chaired. And we think that the tumor has a lot of heterogeneity. And it might be so that we do not biopsy enough different sites, which would lead to a difference in mutational load, neoantigens, and probably PD-L1. Or, that might be the other explanation, in mesothelioma, this might not be the biomarker of choice. We all know that we have patients who respond to immuno-oncology treatment in non-small cell lung cancer, even that we don't see any expression. Maybe this is a sampling error. Maybe there's a better biomarker. And that's why we do this translational research, taking biopsies before and after 6 weeks to see what is happening in the tumor.
More questions? Yes, if not the case, thank you very much. So we're coming back now to the order that was foreseen, and I just want to reiterate a little bit on the topic of immunotherapy, which is the topic of today's press conference. And there were a couple of presentations which have been selected according to their importance sort of in the field because of covering one or the other aspect. And this starts with the presentation of Dr. Brammer. And as you all know, the Keynote 24 study was a study which showed in a selected patient population, selected for PD-L1 overexpression, whether a PD-1 inhibitor, checkpoint inhibitor, which was pembrolizumab, was better than chemotherapy in the first-line setting of non-small cell lung cancer. This was the KEYNOTE-24 study. And of course, here the question comes on health-related quality of life. And that is the topic of the presentation that Dr. Brown will give.
Thank you very much, and good morning. So on behalf of my co-authors, I'll present to you briefly some of the data again, and these are my disclosures. So just to remind everyone, for KEYNOTE-024, this study took patients who had not yet been treated with metastatic lung cancer. Their tumors had to have a PD-L1 tumor proportion score of at least 50%, but they could not have EGFR mutations or ALK translocations, so this was a selected group. These patients were then randomized to receive either single-agent pembrolizumab, given once every 3 weeks for up to 2 years, or standard platinum-containing doublet chemotherapy up to 4 to 6 cycles. Some of these patients could have the option for maintenance pemetrexed if their disease was controlled. And at the time of progression on the chemotherapy arm, patients could then cross over to the pembrolizumab. The primary endpoint of this trial was progression-free survival, and secondary endpoints included overall survival, and the exploratory, pre-specified exploratory endpoints included patient-reported outcomes, which we'll talk about in just a bit, which I presented this morning. But just to remind you that pembrolizumab, as presented this past year at ESMO and published in the New England Journal, did show a superior efficacy over platinum-based chemotherapy, both in median progression-free survival as well as overall survival. And this was recently approved by the US FDA as first-line treatment for advanced non-small cell lung cancer in those patients with a TPS of at least 50% in their tumor. So this was the quality of life scores. It looked at 2 different scoring systems or instruments. One was the EORTC QLQ C30 global health status, and looked at baseline as well as week 15. And as you can see here, there is a general improvement in global health status in those patients who were treated with pembrolizumab, and about stabilization of global health status in patients treated with chemotherapy. And the difference between these 2 scores, mean differences, was approximately 7.8, and this was statistically significant. So based on this, we conclude that pembrolizumab has a clinically meaningful improvement in health-related quality of life compared to standard chemotherapy. Now, some people might argue that a 7-point difference might not be clinically significant, but when you have patients treated with disease such as non-small cell lung cancer, where you have a lot of symptoms, a smaller change may be clinically significant. And this is supported by some publications that say at least a 4-point difference one could consider as clinically significant. So also, we think it's very important to point out this time to deterioration of symptoms. So patients treated with pembrolizumab had a longer time until their symptoms deteriorated compared to those patients treated with chemotherapy. And this was using an LC13 composite endpoint, specifically looking at cough, chest pain, and dyspnea. The deterioration was defined as at least one of these symptoms decreasing by at least 10 points, and then had an adjacent 10-point decrease. So as you can see here in the red curve, patients treated with pembrolizumab had a much longer time to symptom deterioration compared to those patients treated with chemotherapy, which is the blue curve. And so patients treated with pembrolizumab had a significantly prolonged time to deterioration. So, in conclusion, I would say that combined with the superior progression-free survival and overall survival, as well as manageable safety profile that's been presented previously, pembrolizumab may be a new standard of care in the first-line treatment of advanced non-small cell lung cancer in patients with PD-L1 expression scores of at least 50%.
Thank you
Thank
very
you.
much. Thank you very much, Julie. Now, this is obviously a revolutionary study in very many aspects, so you might want to ask and take the opportunity to ask Dr. Brommer right away what the circumstances are. Please, sir.
So, particularly as you stated in your conclusion, prior reports from this study had described the efficacy and the safety. What additional dimension do you think these results add? Should they influence decisions of clinicians and patients?
I think always a worry when patients start treatment is a worry about what sort of symptoms or side effects are they going to expect from treatment. And I think here, at least compared to chemotherapy, there's at least a stabilization of their symptoms and not a worsening of their symptoms on immune therapy compared to chemotherapy. And so again, when we're expecting a improvement in overall survival, we want to also have patients live better. So, and I think based on this data, we can comfortably say that their quality of life is maintained to improved on immune therapy compared to those patients who were treated with chemotherapy. Though, just as was seen by the different, in my previous presentation this morning, we drilled down to specific symptoms and functioning. Patients also had an improvement in some functioning and symptom domains when they were on chemotherapy as well. But I'd like to call out for fatigue. We report across multiple studies the most common side effect of immune therapy is fatigue. But compared to chemotherapy in this study, there was a significant improvement from baseline when it came to a symptom of fatigue in patients treated with pembrolizumab versus those patients treated with chemotherapy.
Other questions? Go ahead.
Again, you kind of were addressing this to a certain extent in your answer, and that is, I wonder, it seems as though the contributors to the quality of life measure you make are both the disease and the treatment. And I wonder if, is it important to tease out the contribution of those two in analyzing data like this?
Certainly, and I think that goes to a change in baseline and then time to deterioration of symptoms, I think also helps us to try to tease those things out. But in the end, it's all intertwined.
All right, so we could proceed then. And I just want to draw your attention to the fact that we've been talking until now mainly about PD-1 immune checkpoint inhibitors, and there's a new, whole new group of new drugs emerging which are directed against PD-L1, and these will be the topic of the next two presentations. And of course, we have, there is an assumption, but of course, we have no proof for this, that PD-1 works exactly the same way as PD-L1, and therefore it was important to make a phase 3 study of atezolizumab, which is such a PD-L1 antibody, versus docetaxel in patients with advanced non-small cell lung cancer. And there will be results from subgroup analysis presented by Dr. Gajil, please.
Thank you very much. Good morning, everybody. So this morning I presented the subgroup analysis of OAK, which was the first randomized phase 3 study, as mentioned, of an anti-PD-L1 antibody in advanced non-small cell lung cancer patients who had previously been treated with one or two different treatments. Patients in this study were randomized to atezolizumab versus docetaxel, and the drugs were continued until progression. There were two primary endpoints: overall survival in the intent to treat population, as well as in patients with tumors that were PD-L1 positive. This data was presented by Dr. Barlesi at ESMO this year, and the overall results showed that atezolizumab did improve survival in the intent to treat population. In addition, atezolizumab improved survival at all levels of PD-L1 expression, with the greatest benefit observed in the patients with the highest level of PD-L1 expression. But even among patients whose tumors did not express PD-L1, a survival advantage with atezolizumab compared to docetaxel was observed. So, as I mentioned earlier today, that the anti-PD-1 data suggests that there are certain subgroups of non-small cell lung cancer patients that may not derive survival advantage with anti-PD-1 drugs over docetaxel, and therefore a subgroup analysis was conducted of this study study to identify any possible differences in survival outcomes between patients treated with atezolizumab versus docetaxel in certain specific subgroups of non-small cell lung cancer patients. And one subgroup that was looked at was PD-L1 by gene expression. As mentioned, previous studies had shown that maybe PD-L1 negative patients don't derive benefit, and the subgroup analysis of OAK suggested that PD-L1 as assessed by immunohistochemistry did show a survival advantage with atezolizumab. So just to sort of provide another way of assessing data with another way of assessing PD-L1, gene expression of PD-L1 was assessed. And this analysis also showed that atezolizumab improved survival compared to docetaxel in PD-L1 gene expressor, high PD-L1 gene expressors as well as low. And so you have now two different methods of PD-L1 assessment that show the same thing, that across several levels of PD-L1 expression, atezolizumab improves survival compared to docetaxel, including in patients with low or no PD-L1 expression. Survival improvement was seen both in non-squamous and squamous cell patients with almost identical hazard ratio, and this is true with other anti-PD-1 agents. As you know, there are agents that we use in non-small cell lung cancer that may not work as well as one histology as compared to the other, but this agent does appear to provide survival advantage in both histologies. Then we looked at certain clinical groups that it would be interesting to know whether these drugs work, and one such group was patients with CNS metastases. There were only 85 patients with CNS metastases that were enrolled on the study, but at least in this subgroup analysis, survival advantage in CNS metastases was observed with atezolizumab. In addition, in a poster presentation done yesterday, there did appear to be a prolongation of time to new brain metastases in the patients with atezolizumab. And finally, there are some concerns that there might be some neurological toxicities with these drugs, but at least in patients in this subgroup analysis, in the patients with CNS metastases, no additional toxicities were seen with atezolizumab. Again, in never smokers, there's data to suggest that the PD-1 drugs may not provide survival advantage compared to docetaxel. So we looked at the 156 patients that were never smokers that were enrolled on the study, and what the subgroup analysis showed was that there did appear to be a survival advantage with atezolizumab in this subgroup as well. At least there was a trend, because this does cross the one line, but this hazard ratio was fairly similar to what was observed in the current and former smokers and in the intention to treat, the overall intention to treat group. So again, suggesting that atezolizumab improves survival compared to docetaxel irrespective of the smoking status. On the other hand, in patients with EGFR mutation positive tumors, similar to other agents, survival advantage was not observed with atezolizumab over docetaxel. And finally, age. There's a concern that maybe in the elderly patients, immune system may not be as active, and therefore there was an interest in looking at whether the efficacy was similar across age groups. And at least a trend towards improved survival was seen across all age groups, including the very elderly patients above the age of 75. So really, in conclusion, the subgroup analysis demonstrates that atezolizumab does have broad activity in several subgroups, particularly across several levels of PD-L1 expression, including both assessed by immunohistochemistry and gene expression, as well as in never smokers. Thank you.
Thank you very much. Thank you. Are there questions, please? So this is an important aspect, particularly the age aspect is important, because there was that is something which was not really sure for a long time. That's one thing. And the other thing, of course, is the new aspect of PD-L1 testing, which is also a very important issue, because as we will hear afterwards from Dr. Adam, there are a lot of different questions concerning PD-L1 testing, including immunohistochemistry, so this opens up a new horizon. Please.
So when atezolizumab or a related drug has activity in a patient that has low or no expression of PD-1 and PD-L1. What is hypothesized as the mechanism of action of the treatment?
I think there are a couple of issues. One is that there is tumor heterogeneity regarding PD-L1 expression, and so it is fairly possible that in the sample analyzed, PD-L1 expression is low, but that may not be reflective of the entire tumor population. In addition, we are not assessing some of the other factors that might be relevant in the activity of both anti-PD-1 and anti-PD-1 agents, such as mutational burden, such as presence of CD8 positive T cells. So PD-L1 might be an important, but I don't think the only factor that determines the efficacy of these agents. And it is quite possible that in the future there would be a conglomerate of several factors that we use to predict which patients are more likely or less likely. And I think in that group of tests, PD-L1 is one. So I don't think we can say it's something like EGFR mutation where patients either respond or don't respond. It is, I don't think, as clear-cut. And that might be an explanation as to why we do see activity in PD-L1 negative patients.
Okay. Further questions? Thank you very much.
You.
So a second compound in the row of anti-PD-L1 antibodies is durvalumab. And that is, again, the question emerging, how well does this work in the late-line treatment of patients with advanced non-small cell lung cancer, mind you, molecularly not mutated. So these are results from a phase 2 study, which was called the Atlantic study, and the data will be shown to you by Dr. Garasino, please.
So thank you. I prepared for you some points. So first of all, I had the privilege to present for the first time the data coming from the Atlantic trial. So durvalumab was, it is an anti-PD-L1, and it was, in this study, it was administered only to patients who were very heavily pretreated. This kind of patients, in their reality, they have a very poor prognosis, and they are the typical patients for best supportive care, and they have a median survival time of 2 or 3 months. So here we have just data, not not controlled, because this is not a phase 3 trial as the trial before. So this is a single-arm trial in this kind of patients with heavily pretreated. The study was done in 2 groups of patients, one for EGFR mutated patients and ALK translocated patients, and the other group was for patients with EGFR wild type and ALK wild type. In my presentation, I focused my attention only to patients with EGFR and ALK wild type, because we know that for patients with EGFR mutated and ALK alteration, there is less effect of this kind of drugs. So this part of the study will be presented in another congress. So for this kind of population, durvalumab showed very long-lasting responses, but it showed also an impressive overall survival. For this kind of patients that in the reality they have 2 or 3 months, the 1-year overall survival time was 48% in patients with PD-L1 more than 25%, and it was above 51 in patients for PD-L1 more than 90%. The drug was very well tolerated. The majority of the adverse events were abnormalities of the thyroid, hypothyroidism, and hyperthyroidism. And as the discussant showed, the abnormalities of thyroid were doubled in the subgroup of patients with PD-L1 more than 90%. This we don't know exactly why, but one idea can be that that this kind of patients have not reached yet the median overall survival, and they are on treatment since a long time. So these results are phase 2 single-arm results, so they are not controlled. There is obviously the bias of selection in this kind of populations, but they are consistent with the other anti-PD-1 and anti-PD-L1 compounds, and we are awaiting for the final phase 3 trial to see the final role of durvalumab in non-small cell lung cancer.
Thank you very much. Any questions from your side? Everybody happy? All right. Everybody happy? Thank you. Thank you. So now comes a very important aspect, not that the others one were unimportant, but this is a quite important aspect which intrigues all of us. And there's the question about PD-L1 testing, because as you all know, there's a lot of different thresholds in different studies. Different companies use different compounds and different proofs for immunohistochemistry positivity, and a lot of immunohistochemistry results are translated to the clinical trials. So in this whole chaos, there are attempts to make harmonization, and it is a very important contribution by Dr. Adam to present a multicentric French harmonization study for PD-L1 immunohistochemistry testing in non-small cell lung cancer. Please.
So thank you very much for the very kind introduction. I had the privilege to present a multicentric study we realized in France as a group of pathologists involved in thoracic pathology. And here are my disclosures. As it has been said before, we have today to assess PD-L1 expression by immunohistochemistry at least 4 standardized assays that were developed in association with the drugs, the 22C3 assay on DACO platform, the 28.8 on DACO platforms, both 22C3 in association with pembrolizumab, 28.8 with nivolumab, and then Ventana platform SP142 in association with atezolizumab, and SP263 in association with durvalumab. And these assays were used in clinical trials, but in real life it's a little bit difficult to use this assay for several reasons. The first one is that all centers and many pathologist labs doesn't have DACO and Ventana platforms available, and this could not be possible to run some of these assays. These assays remain expensive, and at least in our country the reimbursement is not sufficient to perform these assays on a large number of cases in pathology labs. So we might consider to develop some so-called laboratory developed tests, meaning that we take the antibody, the concentrated antibody, and not the kit, and we validate our own test in our own laboratory. Of course, this is something which is not completely standardized, but we expect that in France many pathology will use that kind of test. And another issue is that PD-L1 testing has to be quickly available, in particular for patients that will be treated in the first-line setting with anti-PD-1 or anti-PD-L1 treatments. And multiple tests will not be possible to perform multiple tests on very small biopsies. So our study aimed to see if we can harmonize tests of PD-L1 using these assays, but also using some laboratory developed tests. And what we did is that we worked with 7 centers using the 3 main suppliers of automated immunohistochemistry platform, DACO, Ventana, and Leica, and see if when we use the 4 antibodies used in clinical trials and in kits, and also 1 antibody that has been widely used in research, but which is a research-use antibody, which is the E1L3N clone, if we can harmonize all these tests. And this multicentric study was conducted on a series of 41 cases, which is quite similar to what has been studied in the blueprint study, and we scored tumor cells and immune cell staining. So briefly, what we found is that for tumor cell staining, we confirm what has been described before, that the 28A, the 22C3, and the SP263 assays. So the standardized assays provided by Dako or Ventana are quite highly concordant, and we've got very good concordance rates. And we evaluated 27 LDTs developed locally in the 7 centers with these various antibodies. And what we found is that approximately half of these LDTs were as concordant with standardized assays as the standardized assays are together, and approximately the other half has a poor concordance. So this means that we can use probably LDTs to test patients, but we have to be very careful when using these LDTs, and in particular when validating it. We also found, interestingly, that some antibodies were easier to harmonize on different platforms, and in particular the SP263 antibody, which was a new finding. And for immune cell staining, we observed that there was very poor concordance between assays as well as LDTs. This might be due to several factors, and in particular to the fact that it's more difficult for pathologists to assess the staining in immune cells. So our take-home messages were that the 22C3, 28.8, and SP263 assays were highly concordant, so we might consider using another assay, for instance, the SP263, if we've got a Ventana platform, to test patients for prescription of other drugs, nivolumab and pembrolizumab. And among 27 LDT laboratory-developed tests, approximately half of them demonstrated a similar concordance. So this could be an option to use LDT, but this has to be carefully validated. And this means, in terms of perspective, that every pathology lab which is equipped with automated platform, which is almost all laboratories in the world today, should be able to perform PD-L1 testing, and maybe to use a single PD-L1 testing excepted for atezolizumab, because for two reasons. The first one is that we didn't study the SP142 kit in this study, and the other thing is that it uses the immune cells staining that seems to be more difficult to standardize. Thank you.
Thank you very much. Thank you. Other questions? Please.
I wanted to ask, when you gave the presentation, you said this was part of a program to sort of develop guidelines, I think.
Yeah.
Where are you with that, and how does this fit into the...
So now we have selected the LDTs, and now we will validate them with validation cohorts of samples, and then we expect to provide recommendations in the next month, probably in second quarter of 2017, because in France there's a need really for laboratory developed tests for many reasons I've developed before, but we would like people to have clear recommendations on how to perform them, but how to validate their LDT, because validation, local validation, is very important. And we should also look at the stability of antibodies and what kind of antibodies people use, because the E1L3N, for instance, which gave good results in our study, is right now research use only antibody. So we should discuss that, because we should have antibodies that are very stable in terms of performance, and it's something which is not completely sure with research use only antibodies. So there are other issues that are coming, but this was the first part of the study. Yeah.
One other question is, yesterday when we had some results with drugs, they were talking about the need to perform the testing to make sure we're getting the right patients. How much of it a concern is it that maybe this isn't quite happening in the way that it's desirable?
So can you be more precise?
In order to get the most out of the new drugs,
yeah,
we're doing the testing and to make sure that we're picking out the right patients. And is there a concern that we're not quite doing that yet to the desirable level?
Yeah, from my perspective, the first line setting will be we will perform PD-L1 status systematically upfront from patients who are diagnosed with advanced stage non-small cell lung cancer. We should do it systematically, and we have to do that with a single test. Probably we have to do that with a single test to have a PD-L1 status that could be used for different drugs. We can achieve that probably for SP263, 288, and 22C3. This will not be possible, likely not be possible for SP142. So it depends on tumor type, it depends on, but I think that we should have a first-line systematic PD-L1 evaluation, and this could be combined to other factors. So it's something that could be also interesting to test, such as mutational load or immune infiltrates, or maybe some RNA expression stages.
So if I may say, this is also our clinicians' desire to have this kind of standardization. That is extremely important for us.
I would say that the recent approval is going to now make, so before this approval, not every agent was necessarily based on PD-L1 testing, so there was no added incentive to do the testing. But I think now that the approval in the frontline setting is based on PD-L1 testing, it will become very different.
Which approval is that you're referring to?
Of pembrolizumab as frontline agent. I think this is where Dr. Adams' data has become very important because it's become challenging in various laboratories in USA where to decide which platform to use and which antibody to use. Because yes, the current approval with pembrolizumab is with the 22C3 antibody, but in the future it may not be the same antibody, the same platform. And this harmonization will give us a level of confidence that if you have your own platform, your proper antibody, that you should be able to use those results clinically.
Just to inform you, this was pembrolizumab in the first line, and it was approved by the FDA, I believe, on October 25th. And there we have this, what Dr. Brown was relating to, this population, about 1/3 of all patients, roughly, who do have this overexpression of PD-L1, and who obviously benefit extremely from the treatment and also have a better quality of life. That's why, in fact, everything belongs together, which was shown here today. Go ahead.
Is this the first attempt at harmonization that's ever been done?
No, there are other studies, 4 or 5 other studies. I've presented in the main presentation some data from the Blueprint study, which compared assays, the German study, which was published in Modern Pathology, and the AstraZeneca concordance study, where they evaluated concordance between assays. But this one was particular that we worked in a multicentric study. It was a multicentric study, and we evaluated quite a large number of LDTs systematically, in a systematic way, and we tried to identify. There are other studies based on one particular antibody, one particular platform, and trying to make it concordant with the corresponding assay. What we did is that we take a large number of centers, platforms, antibodies, and then identify which one were the most concordant for further validation. It's another methodology.
I would say that this study is unique in the fact that it's, in my mind, it's very real world.
Yeah, exactly.
Looking at it within one country, across multiple institutions, in the pathology department.
Yeah.
And so, Dr. Brown or Dr. Gadgil, do you think similar kind of analysis needs to be done, say, for the United States? Is anything planned along these lines as far as you know?
I'm not sure if that there's anything planned, but I think it behooves each physician to know exactly what their antibody means when they get a test result back. You know, what antibody is used. If you get a negative versus a positive result, was the cutoff used? In my mind, I like to have a number so I can decide what that means. So.
And I would add that the effort done in France is so good that we wait for the final results, but I do believe that they could potentially be extrapolated. The fact that they've involved multiple labs, multiple investigators, multiple antibodies, multiple platforms, I think extrapolating that data to other countries would be a lot easier.
Yeah. I think the closest in the U.S. right now that's not just within one institution is the NCCN group. The National Comprehensive Cancer Network has done some of this sort of work as well through Dr. Rim at Yale.
All right. questions that you would want to have answered, take the opportunity. Very rarely will you find such experts in the field together in one podium here. All right, it's not the case. Thank you very much for your attention, and please write about us friendly.
Thanks again.
Thank you. All the best. All the best. Pleasure. Right.
Great job on questions for you. Thank you.
Bye-bye. Yesterday with Joe Jacques.
Ah, okay.
Yeah, we're twins in our spirit because he's editing animal ecology. I'm editing Esmo. So we're sort of twins in our spirit. Take care. All the best. Arrivederci, grazie.